Burkitt's lymphoma, BL, is an aggressive form of non-Hodgkin lymphoma that originates in B lymphocytes, a type of white blood cell. It is named after Dennis Parsons Burkitt, an Irish surgeon who first described the disease in 1958 while working in Africa. Burkitt's lymphoma is one of the fastest-growing human cancers, characterized by rapid proliferation of malignant cells. Despite its aggressive nature, it is considered highly treatable when diagnosed early and managed with appropriate therapy. Types of Burkitt's lymphoma. Burkitt's lymphoma can be classified into three main clinical forms, each associated with distinct geographic, epidemiological, and pathological features. Endemic Burkitt's lymphoma. Predominantly found in equatorial Africa and Papua New Guinea. Commonly affects children, with a peak incidence between ages 4 and 7. Strongly associated with the Epstein-Barr virus, EBV, which is detected in nearly all cases. Often presents with jaw or facial bone tumors, though other sites such as the abdomen and kidneys can also be involved. Sporadic Burkitt's lymphoma. Occurs worldwide, including in developed countries. Accounts for 1 to 2% of all adult lymphomas and about 30% of pediatric lymphomas in industrialized nations. Less strongly associated with EBV, with only about 20 to 30% of cases linked to the virus. Typically presents with abdominal masses, often involving the intestines, kidneys, or ovaries. Immunodeficiency associated Burkitt's lymphoma. Occurs in individuals with weakened immune systems, such as those with HIV/AIDS or individuals undergoing immunosuppressive therapy after organ transplantation. May affect multiple body sites, including lymph nodes, the central nervous system, CNS, and gastrointestinal organs. Causes and risk factors. The exact cause of Burkitt's lymphoma remains unclear, but several factors contribute to its development. Genetic factors. Burkitt's lymphoma is strongly associated with chromosomal translocations involving the MYC oncogene on chromosome 8. The most common translocation is T814, which juxtaposes the MYC gene with the immunoglobulin heavy chain enhancer, leading to overexpression of MYC and uncontrolled cell growth. Epstein-Barr virus, EBV. EBV, a herpes virus, plays a significant role in the development of endemic Burkitt's lymphoma. The virus infects B cells and promotes their proliferation, increasing the risk of malignant transformation. Immunosuppression. A weakened immune system, due to HIV infection, organ transplantation, or certain medications, increases the likelihood of developing Burkitt's lymphoma. Environmental factors. Exposure to malaria is a significant risk factor for endemic Burkitt's lymphoma, as it suppresses immune control of EBV-infected cells. Symptoms. The symptoms of Burkitt's lymphoma can vary depending on the location and extent of the disease but commonly include abdominal symptoms, pain, swelling, or a noticeable mass, often accompanied by bowel obstruction, nausea, and vomiting. Facial and jaw tumors, most common in endemic Burkitt's lymphoma, leading to swelling and disfigurement. Systemic symptoms, fever, night sweats, weight loss, and fatigue, commonly referred to as B symptoms. Neurological symptoms, if the central nervous system is involved, symptoms may include headaches, seizures, or changes in mental status. Diagnosis. Diagnosing Burkitt's lymphoma requires a combination of clinical evaluation, imaging, and laboratory tests. Biopsy. A tissue biopsy from an affected lymph node or mass is essential for definitive diagnosis. Pathological examination shows a characteristic starry sky appearance due to interspersed macrophages among rapidly proliferating malignant cells. Immunophenotyping. Flow cytometry or immunohistochemistry confirms the presence of specific markers, such as CD10, CD19, CD20, and CD22, which are characteristic of Burkitt's lymphoma. Genetic testing. Detection of MYC translocations using fluorescence in situ hybridization, FISH, or polymerase chain reaction, PCR, is diagnostic. Imaging. CT or MRI scans are used to determine the extent of disease and involvement of other organs. A PET scan may also help assess metabolic activity. Bone marrow and CNS evaluation. Bone marrow biopsy and cerebrospinal fluid, CSF, analysis are often performed to assess for systemic or CNS involvement. Treatment. The treatment of Burkitt's lymphoma involves intensive chemotherapy, which has a high success rate when administered promptly. Chemotherapy. Combination regimens such as Codoxem/Ivac, cyclophosphamide, vincristine, doxorubicin, methotrexate, ifosfamide, etoposide, and cytarabine, are commonly used. Intrathecal chemotherapy is administered to prevent or treat CNS involvement. Targeted therapy. Rituximab, a monoclonal antibody targeting CD20, is often added to chemotherapy regimens to improve outcomes. Supportive care. Management of complications such as tumor lysis syndrome, a metabolic emergency caused by rapid tumor breakdown, is critical. Stem cell transplantation. In rare cases of refractory or relapsed disease, autologous or allogeneic stem cell transplantation may be considered. Prognosis. The prognosis for Burkitt's lymphoma depends on factors such as the stage of the disease, patient age, and overall health. With modern chemotherapy regimens, cure rates exceed 90% in children and adolescents with localized disease. However, the prognosis is less favorable in adults or individuals with advanced or relapsed disease. Conclusion. Burkitt's lymphoma is a highly aggressive but treatable malignancy. Early recognition, accurate diagnosis, and prompt initiation of intensive chemotherapy are essential for achieving favorable outcomes. Advances in research and therapy continue to improve survival rates, offering hope to patients diagnosed with this challenging disease.
Thank you for watching. Please subscribe our channel.